So, welcome everyone. I'm so happy to have you here, and we will go ahead and just kick off and get started. Welcome to Survivor's Gynecologic Cancer Awareness Month webinar. And before we really jump in and get started, I'm going to cover a few housekeeping items. So, next slide, please. Please make sure to keep your microphone muted, and this helps us minimize background noise so you can really listen into our speakers. And if you have questions throughout the presentation, feel free to use the Zoom feature of Q&A, or you can go ahead and put those in the chat. If you want your question to be private in the chat, please make sure you're only sending your chat to host and panelist. And if you're okay with your question or any comments being seen publicly to the entire webinar group, you can make that feature in the chat be clicked over to everyone. And also, we want you to share excitement with us. So I know September is rounding out, but it is still September. It is still Gynecologic Cancer Awareness Month. So feel free to share your excitement about this webinar after the webinar with our hashtags, hashtag Cervivor, hashtag GCAM 2025, hashtag End Cervical Cancer, hashtag Silent No More. And just so you know, this webinar is being recorded, and all registrants are going to be notified when the recording is available on Survivor's YouTube channel. So enough with the rules. We are going to go ahead and really jump in now. And to start with that, I wanted to introduce myself to you. I'm Lauren Listowskis. I'm a cervical cancer survivor. I'm a survivor ambassador, and most recently came on to help the team out and am the Survivor program coordinator. And really, of course, Gynecologic Cancer Awareness Month has always been important to me as a cervical cancer survivor, but a few years ago, the meaning of it really changed for me. And I ended up being the primary caregiver for my mom when she was diagnosed with stage 4 ovarian cancer. Unfortunately, just 6 months after her diagnosis, she passed away. And so that is why GCAM and Gynecologic Cancer Awareness Month means so much more to me now than it ever did before. So, why are we here tonight? Well, I think you all know gynecologic cancer matters, and talking about it matters. Bringing awareness about this topic matters, and hearing people's stories really does matter. This month, Gynecologic Cancer Awareness Month, is really bringing awareness to the 5 main types of gynecologic cancer, which, as many of you probably know, include ovarian cancer, cervical cancer, uterine cancer, vaginal cancer, and vulvar cancer are the 5 main types. And tonight, this is important, not just the voices, not just the stories, not just the information, but gynecologic cancers are prevalent. They might not be in the news as much, but approximately 100,000 women in the United States will be diagnosed with a gynecological cancer every year. So this really does matter. Bringing awareness to this topic really matters. So with that, I'm going to let us jump right in. So tonight you're going to hear from a few survivors. You're also going to hear from a few experts. And then as long as we have time, we'll round out with questions. So feel free to put any questions, any comments in the chat. We will welcome it. And if time allows, get over to those. So we're going to kick off. Next slide, please, with Sandra. So I'm so happy to welcome Sandra to our webinar. Sandra is an endometrial cancer survivor and ambassador of Endometrial Cancer Action Network for African Americans, also known as ECANA. Sandra, go ahead and share a little bit of your story with us. Thank you.
Hi, everyone. I'm glad to be here. My story started back in September of 2023. I went for my annual PEP exam. I was experiencing some spotting. My GYN, she suggested that she take a look. We did an ultrasound, saw some thickening around the wall of my uterus. She did recommend it to DNC. I had that done in September. Came back that they had found some cancer. I was then diagnosed, had my surgery in November of that year. I had type 1, um, stage 1A, serous carcinoma, endometrial cancer. Went from there to had radiation treatment, had the radiation treatment. But it was something we it started the cancer, everything. I was a little nervous and about deciding on the type of treatment I was going to have. But in the midst of having that surgery in November, I did have a complication where I did actually have to have a second surgery just a couple of days after that first surgery. It was a very, I guess, very heavy experience for me, not expecting to receive that diagnosis, and had a full total hysterectomy. Um, there was some emotional turmoil there to make the decision on what was the best treatment for me to take had, and what really helped me, and the support that I gained. I had support from my family, which was very helpful. My husband, my faith, number one. But then I got connected because when I was going in between of trying to decide, well, what should I do? What kind of treatment should I have? I needed to get some type of support. And that was and then I went to my oncologist and shared my concerns with her. And she suggested Ikana. That's how I got connected with the group of Ikana. And that's a group of women that I just felt that I could be absolutely myself with. I could be real with. They shared their experiences with me. I was connected with a one of the women, and she shared with me, which really encouraged me to move forward into having that treatment. And then from there, I am now an ambassador of Ikana. I've learned how, and through them, through the education and the support system that I had through with them, I am now become that advocate. It is important to me that I also make others aware of this. We as about the endometrial cancer, because it is so important that I get the word out. So that is something that I'm very happy and wanted to share that with everybody. I can honestly say that I didn't always felt that way, but I feel that it is so important, and I am very passionate about this now, and I'm so thankful for my relationship that I have as being an ambassador and a advocate, because I definitely, and I've learned that it's so important that we advocate for ourselves, and that's something that I'm 100% involved with now, and getting educated about my experience. But that's kind of where I am right now in a short little summary of my story.
Thank you so much, Sandra, and thank you for sharing. And we're so happy to have you here and have your voice out there advocating. So thank you. All right, so next we're going to jump in and hear from Dr. Lee. Dr. Lee is a gynecologic oncologist at the University of Chicago, and we are going to get to hear from Dr. Lee about all kinds of things related to gynecologic cancers. So, Dr. Lee, if you could introduce yourself and kick us off with your information.
Sure. Great. I will say that like I had a little bit more focus on cervix, but I do actually have a slide deck that I can easily switch in if you want me to cover more things than that. And I apologize in advance if I think I missed something. But I want to make sure, I really appreciate being able to kind of talk through all the GYN cancers, but I think we can do this in relationship to the slides that I have right now. So should we start with those, or what do you guys think?
We'll follow your lead, Dr. Lee. We trust you.
Okay, let's just start with the ones that I have, and I feel like there's plenty to talk about in between. Okay. If you could go to the first one. this, I hope this is the right one, but let's see. Yeah, if you can switch to the first slide and okay. But I know you guys, I guess I hear you're saying I follow my lead. I'm sort of torn now. I'm like being put on the spot, but
Do
let's
you
start
want
with
to
talking.
not use slides, Dr. Lee? Because that's totally fine too. And I have a toddler, so I'm keeping it short.
What was that?
Chayton's here, so I'm keeping it short.
Oh, sure, sure, sure. Well, let me start with a little bit of these slides, and then what we'll do is, I know there's not a lot of time, but I definitely can also share like more slides that are on all GYN cancers. And I, again, apologize for my thinking of like what we were talking about tonight. That was on me. But so, okay, let's go through it. We'll go from there. And we'll use different examples to kind of talk through how this could be related to all of the GYN cancers. And I'll kind of do some comparisons and some different ways of connecting. So one of the things I think about when I think about Gynecologic Cancer Awareness Month is I think about Henrietta Lacks. And have you guys, I know you have done some with Cervivor, have done some focus on thinking about Henrietta Lacks and the legacy of Henrietta Lacks. And I don't know if everybody is familiar with this, but who was Henrietta Lacks? I think, a lot was known because of the fact that they made a book out of her life and a movie from Oprah. But she was actually a 30-year-old woman who was from Maryland. She was born in 1920. She was a wife, mother, sister, cousin, patient, friend, a community member, a cervical cancer patient, an African-American woman. And I think this is really important, even beyond just cervix cancer, because it really speaks to the idea of like women getting recognized for symptoms, like how do we how do we think about this cancer? And this was back in 1920, right? So she was diagnosed with cervical cancer 4 to 5 months after the birth of her son, and unfortunately died at age 31 from a very aggressive form of cervical cancer. So I think about this because I often think about like who are the people that we are doing this for, and who are the people that are maybe not with us now, or who are the people who we really want to kind of prevent from joining the group of survivors, in terms of like we want to try to think about prevention, early detection, better treatment, and also less toxic treatment. So in terms of like cervical cancer, we think about 13,000 women will be diagnosed. But as mentioned, when you think about all the GYN cancer, that's 100,000 women. So like uterine cancer is actually increasing. So thank you, Sandra, for sharing your story and the work that ECANA does, because uterine cancer, and also known, the more common uterine cancer is called endometrial cancer, is actually increasing by 1 to 2% every year. So the slides that I used to make when I was a junior attending 15 years ago actually have changed because we keep seeing this increased slope. But very similarly, these are women who are not necessarily acknowledged for bleeding and for workup of bleeding. And that's about 60 to 70,000 women per year now that are diagnosed with uterine cancer. Ovarian cancer, thank you, Lauren, for sharing your story as well, is often something that we really, we don't have a screening test for, but we really need to do is to kind of think about paying attention to women, their symptoms, having women and providers more aware of the symptoms of ovarian cancer. So we can think about that, and that about 22,000 women are diagnosed with ovarian cancer every year. And unfortunately, about 13,000 women may die of ovarian cancer as well because of how lethal it can be. And then we have vulvar and vaginal cancer. So we think people don't like to talk about below the belt cancers. People really don't like to talk about below the belt cancers, right? No one's heard of vaginal or vulvar cancers. This can be particularly important in our patients who are getting older, like older than 65, 75, those kinds of things. I will borrow a line from one of my lovely collaborators and friend, Vanessa Hill, who started an organization called Project Nana, and she talks about seasoned women, right? And so I like that line to think about, like, what are things that we need to think about. So we can kind of think about Henrietta Lacks as an example of a woman who was diagnosed with cancer and had to have a significantly toxic treatment, and unfortunately passed away. She's more well known because the cells of Henrietta Lack were taken and used and actually became a really important scientific resource without, unfortunately, acknowledging her or her family until like 50 years later, right? So that's a whole other conversation, a whole other webinar. We'll go on to the next slide. So when I think about fast facts, we think about cervix cancer, which many in the group may already know about. So anyone with the cervix is at risk. The most common age, the average age, 20% are still diagnosed after the age of 65 because people don't read the fine print on that. Most at risk if you've not had a pap test or an HPV test in 5 years. We know it's preventable and treatable. It's not to blame anyone who hasn't been able to do those things, but it's just to know that we can try to get people back on track. And before you, between 50 and 65, getting those like pap smears to make sure you can graduate out from getting them at 65 is important, because the women who get cancer after 65 never got their pap smears in the recent years before that. Next slide. So I'm going to show this age group, and this is about cervical cancer, but this is kind of important to we can talk a little bit and use this, and I won't have the slide in front of me, and I'm happy to switch out those slides and talk about like what happens to the other cancers too, So cervix cancer, the median age is around 50, and you can see that there's a lot of women, we are diagnosing them in their 30s, 40s, and 50s is kind of this like lump of like late reproductive age women and earlier menopause women. It's a little bit, and 20% will be over the 65. This is really important because we want screening to start at age 21. We want it to go to 65, but at 65, we want to make sure in the 10 to 15 years prior to that, you got screened. Endometrial cancer median age is more around the lines of 60 to 62, as is ovarian cancer. So it's a little bit more of a diagnosis of postmenopausal patients. It doesn't mean it always is, because we know that there are some ovarian types and endometrial type of cancer that can happen very early. So the youngest I've taken care of somebody with endometrial cancer was 26. And sometimes that can be due to a hereditary predisposition, or sometimes it can be sort of a random event. Some of the things that predispose women to having it younger could be a hereditary condition. It could be for uterine cancer, problems with fertility, cycles that were irregular. All of those things have to be factored in when we think about the risk and what age a cancer can occur in. Next slide. Cervical cancer incidence rates. We kind of put it up here because there are disparities in all of our cancers in terms of like how people do and who gets these cancers. So cervical cancer incidence is actually highest in American Indian, Alaska Native populations. And this is from 2019, but that's pretty much stayed the same when I've looked at the more recent data. Hispanic women, non-Hispanic Black women, and then white women and Asian Pacific Islander. It doesn't mean that like we all are at risk for all of these things. Ovarian cancer tends to be a little bit more evenly split as well as endometrial cancer, but the problem becomes in endometrial cancer, the issue is that there are different types of endometrial cancer, and Black women are more likely to get one of these higher cell types that can actually behave more aggressively. So that can actually affect outcomes in terms of them having potentially because of those cell types, Black women we know have higher mortality rates from endometrial cancer. So when we think about endometrial cancer and cervical cancer and ovarian, we think about a lot of different reasons why mortality could differ. Sometimes we think about access, right? Who is getting listened to, who's getting insurance, who's getting like heard in their doctor's office in terms of getting like quick referrals. My dream is to like somebody to give us $1 zillion to have like a community concierge program, right? So like, like what happens if there's like a VIP, somebody's like, oh, call this person, and like the VIP gets an ultrasound and the and our job is to kind of make sure that everybody gets that type of treatment, right? So I think some of those things are access. Some of them can be different, other biologic, not that anyone's biology is different, but just these patterns of histology types. And then some of it can be whether or not women are equally getting guideline care that's quality. So those are kind of some different elements of like where and what we can think of in terms of the disparities. Next slide. So in terms of deaths due to cervical cancer, we still see that Black women and American Indian, Alaska Native women have the highest death rate due to this cancer, and this disparity really persists. I will say that some of this also is important to look at the geography, because the highest rate of increasing cancer rates is actually happening in white women in kind of the Appalachian states, and in states that did not expand Medicaid. So when you look at, like, the poorest counties and where cervical cancer is rising, it really doesn't care your race or your ethnicity. It's really related to like poverty and access in some ways. And so some of the things we're seeing in the US are actually white women in certain states having the highest risks of mortality as well. So next slide. We talked a little bit about this. I mean, this is kind of like a hard thing, but I think it's, I put this slide up here just because we see the wide range of that happens for GYN cancers. And this could be really a slide that you just shift over a little bit for ovarian and for endometrial to be slightly older. I think it's important because we think about GYN cancers affecting women across their lifespan, and thinking about how we think about this. Next slide. So I do feel really strongly about this because I don't think anyone, I mean, I think we should probably be trying to fight all of these cancers, but cervical cancer, because it's preventive, I think this is the problem, right? That we have ways to prevent this. And so we want to make sure we're taking action on this. We also have other ways that we can reduce risk and prevent the other cancers, right? So when we think about endometrial cancer, some of the risk factors are not preventable, or they're just related to age, or like different other elements, but some things are, there's certain elements of endometrial cancers that are related to choices in terms of that we can try to make better, even though we don't know all the right answers. Diet, physical activity is one of them. I never want to introduce this with the idea that somehow endometrial cancer is the one that you could actually prevent and it's people's fault if they get it, right? That's not true. We don't know why. The same person, same weight, same height gets it. Somebody does, somebody doesn't. There's a lot of other genetic and molecular factors and environmental factors. But we know that there's this trend. So even in women who are the same weight, we know that women who are more physically active actually have less endometrial cancer, right? So there's like a preventive measure without being like very strict about BMI or something like that. We know that diet quality matters. And so those are elements that are important. We also know that endometrial cancer and fertility are an issue. So we really need to think about reproductive age women throughout. With ovarian cancer, one of the biggest things we think about prevention is knowing your cancer genetics. Because if you can get genetic testing, you may be able to prevent that in the next generation through use of birth control pills or risk reducing surgeries. So there is like a range of things that we can do to make sure that we're thinking about all of the things that are in the screening category, and then all the things that are in the potential risk reduction category. Next slide. So who is still getting cervical cancer? People who miss screening, they get screening, but they don't have follow-up. They're uninsured, rural communities, disabled patients, immigrant patients, and immunosuppressed patients, which includes HIV and transplant. It's just sort of an important thing about the Swiss cheese effect of like who's getting these cancers. I think the same exact thing you could argue is the same thing if you said understanding who is still getting advanced gynecologic cancers, regardless of which cancer that is, right? And that's actually really important to kind of think about in terms of like disparities as well. Next slide. So the screening rates in 2021, 75% of uninsured patients, recent immigrants, and people without a high school education. So you can see how access, a job that's convenient and can give you time off, those kinds of different elements, things can be an issue related to cervical cancer screening. We can skip this one. We'll keep going through here too. Barriers, we've talked about stigma, other health issues, lack of time, no provider recommendation, discomfort with exams. This actually can really apply to any GYN cancer, right? So if we think about barriers to just the diagnostic process for GYN cancers, that's how I would think about this slide, right? So lack of time. I have some problems. I have some pain. I may not have time. I might be embarrassed. I don't like to talk about below the belt cancers. I went to my doctor to complain about these symptoms. For example, ovarian cancer. Many times women have had complaints of bloating, changes in their urinary symptoms, changes in their bowel habits, irregular bleeding, and sometimes they're discounted, right, as having all these things. I see Lauren saying I have a minute left, so let's keep going through these slides. You can, we'll just have them all. Keep going. I'll tell you when. Pelvic exam, if you, everybody can pass on that a pelvic and a pap are not the same. So we know that a pelvic exam, pap smear, separate test. Keep going. Keep going. I think we can do all of these things. Why don't I just stop here? Because I feel like there'll be a lot of other things that we can talk about, but I don't want to belay this because there's so many really good topics. I think one of the things that I would say, you can, if you want to just end the slideshow and then we can just see if there's any questions that people have or want to comment on. I think the theme that I would say that are really important are the fact that like symptom recognition by patients and then symptom recognition by doctors are equally really important. And so our job as people who want to advocate in these spaces are telling patients what are the symptoms you should look out for. And I'll be happy to send something to Lauren to give to everybody that's a little bit more general about all of the GYN cancers. And then also feeling free to advocate if you're not getting those answers discussed or action on them, right? Pelvic exam, pap smear, ultrasound, or CAT scans. And I think that like we just don't recognize them and tell people that it's okay to think that something's wrong with your body. And we often tell our own friends and family ways of minimizing these symptoms, right? We're like, it's probably just menopause. Oh, you probably just have this. Or, young patients will be told it's just endometriosis or it's, but and not everything's going to be cancer, but that idea of advocating, I think, is probably like the biggest message that I think advocates such as yourselves can do a really important job of sharing. Like if it doesn't feel right, like get somebody else to look at this, right? Or don't
Absolutely.
ignore it and like get another doctor, honestly. So anyway. So
Absolutely.
yes, so that's probably my biggest message. And I don't know, I can't really see the chat to see if there's any like
That's okay.
yeah.
We have a lot of folks in the chat just kind of echoing that they also ended up ignoring what turned out to actually be symptoms of a GYN cancer, but they didn't know it was at the time. And even some people, Anne mentioned in the chat that her OBGYN dismissed her symptoms. So, things like you were mentioning, right? Are we being listened to? Do we know what's normal and not normal? I know I personally kicked away my symptoms saying it was stress. That's why I was having, bleeding after intercourse and different vaginal discharge, which looking back, those were definitely symptoms. And I know for my mom with ovarian cancer, she was kicked around between seeing an OBGYN and the gastroenterologist. Is it GYN? Is it GI? Is it GYN? It's GI. And everybody kind of kicking her around a little bit, trying to supposedly find out what was wrong. And by the time the right imaging and the right testing was done, she only lived 6 months after her official diagnosis. So everything you're saying, Dr. Lee, I think people in the chat are really agreeing with. So thank you. And yes, we all go ahead and get information from Dr. Lee that we can share out after the webinar. So
And I'll
everybody,
send my other slide deck that has all the GYN cancer things in it too.
perfect. Thank you so much, Dr. Lee. All right, so we are going to move on to another survivor story. So we have Mihal with us, and she is an ovarian and endometrial cancer survivor and patient advocate. So Mihal, if you would tell us a little bit about your survivor story.
Sure. Thanks everyone for joining and for listening to my story. When I was 45, I was very overweight. I was over 300 pounds. I was working as an executive, so working very long hours and really not taking care of myself. I had back pain. I had really bad periods that had been heavy for years. And I really didn't take time to go to the doctor, didn't think of anything. Because if it was someone else's thing, I would make sure they took care of it. But for me, I just didn't. And in March of 22, I went on a school trip with the organization I was working for, and my legs swelled up to a point that I couldn't walk. I waited 4 days to go to the doctor, and they sent me for a scan. And we found out that I had bilateral DVTs, so blood clots in both legs. And they put me on a blood thinner and let me leave the hospital. And the only reason I even brought up to any other doctors that I had these blood clots was because I had to travel 2 weeks later, and you can't travel without being cleared, especially if you have blood clots. So what went from like a leg cramp ended up becoming the beginning of my journey. Um, 2 weeks later, I was able to fly on a 4-hour flight to Dallas. I had reached out to my doctor and mentioned to her that I was on a blood thinner, and my OBGYN scheduled a transvaginal ultrasound. I had no idea why she did that because we had done so many of these before, and I would have been diagnosed with endomyosis, so I didn't really see a point in it. I got really sick when I was in Dallas, to the point that I didn't think I was going to make it on the plane. And 2 days later, I almost didn't take the scan that saved my life. Um, the transvaginal ultrasound was a tough one, and the tech there said that she couldn't find my ovary, and I thought it was just because I was very heavy. And I left the exam just feeling bad about myself, only to find out the next morning in my chart that there was a 10 centimeter mass on my left ovary, which meant that I would go to the doctor an hour later, get cancer markers taken, and within the next week, I went from leg cramp to needing an oncologist to being tested for uterine cancer and finding out probably a week later that I had tested positive for uterine cancer, which meant that they would have to do surgery not only to remove the mass on my ovary, but that they would have to do a full hysterectomy, oophorectomy, and exploratory surgery as well, because they weren't sure if it was two cancers or one. And they prepared me for it being later stage. And I think I called it my double whammy because at that point I thought I still had time to have kids of my own, and that got knocked out very quickly by the doctors, and no one was going to do anything to save my ovaries at that point. It was too dangerous. So I had my surgery and woke up from the laparoscopic surgery that was supposed to be an hour, ended up being 5 hours to find out that I needed chemo. So I ended up with 6 rounds of carbotaxol, a lot of side effects, some of which I'm still living with today. Lost my hair, had to go on medical leave, and really my life was turned completely upside down. But throughout my journey, I was able to meet some incredible people in this community. And I remember talking to my doctor, who had said she would be with me every step of my journey. And I was having a particularly hard time by the third round of chemo, and she introduced me to a bunch of support groups, and one of them was a young adult group. And from that group, I met other people and eventually got to meet the Cervivor community. And each group has a unique focus, but it was so nice to have people who understood and spoke my language. So much so that I've been inspired by my cancer journey to go back to school, to go into oncology social work, and to become a patient advocate. So I now sit as a patient advocate on everything from helping to build a survivorship program at the hospital I was treated at, to reviewing medical data, to advocating both for cervical cancer prevention as well for GYN cancers, because many people with ovarian don't realize that there is no test for ovarian cancer, and they think a pap smear will clear them for all GYN cancers. And really thank the community for helping me get to where I am today.
Thank you, Mihal. Thank you so much for sharing your story and all the work you're putting in now to advocate and help others. So now we will go ahead and move on to our next speaker. Dr. McCullough is a physical therapist, and she developed the pelvic health therapy program within the University of Kansas Health System. So she is here to talk to us about some side effects, and what exactly pelvic floor therapy is and how it can help people in our situation with GYN cancers.
Hi, thank you all so much for being here this evening. And your stories have been so impactful. I can't say that I have had any of these experiences myself, other than my grandmother actually did pass away from ovarian cancer at a very young age. My dad was only 5 at the time, so I never got to meet her, but it's always kind of been in the back of my own mind with my own healthcare. And because of these experiences and some scares that I have had, I am on my doctors very, very hard. Like, nope, I would like for you to look at me regularly. I want all of the testing possibly done, but completely understand when people just don't know. Let's go ahead and go to the next slide. So just and go on to the next one. So just a little bit about me. Like I said, I am a pelvic health therapist at the University of Kansas Health System. I am a certified pelvic health therapist, a certified strength and conditioning specialist as well. And I'm also a United States combat veteran. So in the Army, I was there for under 7 years, and I was a Chinook crew chief. So if you don't know what a Chinook is, it's that helicopter down in the right corner, and that is me dead center. And top right is what I could have been doing quite often over in the Middle East. And you see all my lovely little fur babies here. But I am very passionate about pelvic health therapy, so I can go on ad nauseum. And so I'm going to try to keep this as succinct as possible. So next slide, please. And we can just go ahead and skip that one, go to the next. So very briefly, some of the very common treatments for cervical cancer from the medical perspective is going to be surgery, radiation, chemotherapy, a combo of chemo radiation, and then any of these other interventions as a combination. And it's going to be based off of your treatment, the diagnosis, how far along the cancer is, and any decisions between you and your doctor. Next slide. And this is a big list, and these side effects of these treatments can be dependent on exactly what type of treatment you have, and not just for cervical cancer, though. It's quite common to see some of these symptoms post-treatment for endometrial cancer and vulvar cancers and ovarian cancer as well. So some of the big ones: urinary and bowel dysfunction, sexual dysfunction, pain. Commonly, pain can be experienced in the pelvis, the back, the abdomen, the hips, the thighs, and the pelvic floor can refer to all of those different areas. Scar hypomobility, so lack of movement within scar tissue, which then doesn't allow your musculature and other structures to move as well as it could. Osteoporosis, fatigue is a really big one. Lymphedema. So Mihal talked about the legs swelling, and the lymphatic system helps to drain all of that out of the regions. And when these systems are taxed, that fluid builds up. You can get a lot of cognitive changes, difficulties with daily activities, neuropathy of many kinds, to include muscle cramping and vasomotor symptoms. And several of these can result in vaginal canal changes because they're removing tissue and it can shorten the canal. Radiation makes the tissues tight wherever it is applied. And some of these can actually change the function of the cervix and its integrity if it is left intact. They can have nausea and vomiting, skin changes, anemia, and leukopenia. So those last few we can't do much about in physical therapy, but a lot of this other stuff we can. Next slide. So just briefly touching on some of the benefits of pelvic health therapy. And I know the dead center of this says physiotherapy. So any physical therapist outside of the United States is known as a physiotherapist. So don't be confused by that. We all do the same thing. You can read those there, and I'm just going to go right into some of these things that we're going to get into. So next slide, please. Okay, so a lot of what we do is starting out with patient education. A lot of people don't even know what normal bowel and bladder function looks like, what normal sexual function looks like, even without cancer. So we're going to educate you on what is normal and how can we help you get back to as close to as normal as possible, if not absolutely normal. We do lots of education on the changes in your anatomy and physiology after these treatments so that you better understand why you're experiencing what you're experiencing. Let's see, pain neuroscience is another one. Some people's bodies get really good at making pain after they've suffered a traumatic experience. And understanding how your brain interprets these things has actually been shown in the research to help manage overall pain. So some of us have that education that we can give to you. I'm going to teach you techniques that you can actually do yourself. That is actually a lot of what physical therapy in general does. We do our assessments, we see what your deficits are, what you're struggling with, and we give you the tools to help yourself that you're able to do, and we take over with the rest. We also teach you what on earth is the pelvic floor? What does it do? So many people have no idea. They're like, I have muscles down there. I'm like, oh, yeah, we've got a lot of them. And they do a lot of work. They control bowel and bladder function. They are important for sexual function. They help with blood and lymphatic flow throughout the abdomen and pelvis. And they are stabilizers. They stabilize your pelvis for all of those forces that are going up and down through your body. Very important muscle group. Vaginal dilation is another really big one that this patient population and all of you are probably familiar with. But with the tightening of the tissues, the shortening of the vaginal canal, the sexual dysfunction that can occur, things can tighten up. And we essentially use these devices, these dilators, to create space to make things much more functional, mobile, and a lot more comfortable for you. And all of this is going to depend on what your needs are, what we find with assessment, and what you tell us is important to you. Next slide, please. All right, us being physical therapists, we're going to do some exercise. And it is going to, again, be dependent on what we find. It's going to be graded based off of your tolerance, and we're going to meet you where you're at and gradually build you from there. And some of the possibilities, postural training. Your posture does play an important role in pelvic floor function, your ability to breathe, GI mobility, bladder control, prolapse, all of it. You could wind up doing some strength, endurance, stability, and coordination training, maybe more on the flexibility, mobility, relaxation side. Lots of patients who undergo these treatments actually have tight pelvic floors. And if you try doing Kegels with a pelvic floor that's already tight, you can actually make it worse. So some people have to work on relaxation, stretching, calming the system down before you can take it to that. Deep breathing is another big aspect, not just for pelvic floor relaxation, but mental well-being, neurological quieting, again, helping with constipation. The pelvic floor is very responsive to balance. So if we have some balance deficits, it tightens right up. And so we can work on that if it's needed. And then we try getting you back to doing the things that you want to do. If you're wanting to get back, I saw somebody pop in Pilates. Pilates is fantastic. If you want to get back to Pilates, or if you're a runner, or if you just want to, get moving, we get you on a walking program. It's whatever you're looking to get to, we can help. Okay, next slide. Laundry list of benefits to exercise. So it can help with that cancer-related fatigue. I know it's something that kind of sounds a little bit backwards, but getting up and moving, even when you're feeling really tired, it can give you a little bit of a burst of energy, and you might find that you feel better and you keep moving within reason. We do need our rest as well. It can help improve mental well-being, keep your bones and muscles stronger and healthier, helps with heart function. And I put specifically on here the coordination because so many people deal with stress incontinence and prolapse, and we need that coordination coupled with our breathing to help reduce those symptoms and support and close everything. And it can help with sleep, pain modulation, and it also helps reduce risk of cancer recurrence and mortality rates. Also helps with fall and fracture prevention. And something else I found really interesting. So on the sexual health side of things, we do know that, again, the pelvic floor is very important for sexual health. I came across this study that talked about exercise-induced orgasms. I can't say I've ever had any patients mention that exercising causes orgasms, but what a bonus if it does. So what the exercises they found where it was actually happening in some women was abdominal exercises, running, walking, hiking, yoga, and weight training. I just don't know that if I'd want to be in a gym with that happening. I'd probably get really crazy looks on my face with me trying to contain myself, but that could be a nice bonus. Next slide, please. So additional things that we can help guide you with in terms of that cancer-related fatigue, aside from exercise, is teaching you energy conservation strategies. So trying to help you understand some of the things that are important for you, things that you really want to prioritize in a given day, and understanding that you don't have to get it all done in one day. And if you want to hit a little bit at a time, we can help guide you through that, and kind of going based off of a quarter tank of gas rule, understanding where you're kind of starting to reach your limits so that you can actually take time to rest so that you're not wiped out for days on end. We can help with nutrition to a point, but if it's a little bit above our pay grade, we can probably recommend that you see a nutrition or a dietitianist. And although cognitive behavioral therapy is not part of physical therapy, it is helpful for cancer-related fatigue. And again, we can always refer. Next slide. Manual therapy, working with our hands, putting hands on patients as they allow, and utilizing tools to help us get tissues moving is so valuable. They've done lots of research that found that just putting hands on people helps with their mental well-being, helps them feel more connected, and helps them feel better. Now, everybody has their own different, let's say, tools in their toolbox in regard to their strategies and techniques that they've learned that worked for them and help with their patients that are dealing with some of these issues. What you see here at the top right, it could be working on abdominal colon massage or fascial mobilizations. The bottom is cupping. Everybody has their own techniques, but they can be very beneficial. Next slide, please. And here's the benefits of manual therapy. So again, we can help regulate pain, increase range of motion, tissue movement, flexibility and mobility. We can help with constipation. I keep mentioning constipation. It's probably the number one thing I see in the clinic. So I treat lots of constipated people. It can also help reduce that lymphedema, and it's commonly coupled with compression. At the University of Kansas Health System, we do have certified lymphedema therapists that specialize just in that. So if I have a patient that really needs some help, I get them a referral and they see someone in the same hallway that I work. They're wonderful. We can help you improve your function, your mood, bowel and bladder symptoms, nausea, fatigue, the list goes on and on. And some of these techniques we can even teach you how to use yourself. Next slide. So I did want to put this one specifically in here because this are some of the techniques that can be utilized directly to the pelvic floor muscles themselves, but technically we can use manual therapy wherever it's needed. So, if your rib cage isn't moving very well, and that's part of why things are kind of gummed up, we can get those ribs moving better. But the pelvic floor, again, if it's really tight, it is not allowing things to move through very easily. It can affect bowel and bladder function when it is really tight. We do need to get those muscles moving. There are some things we can do from the outside if you're really not comfortable with anything being internal. So don't feel any pressure to say, okay, I guess we just have to do this. It's at your own comfort levels. And I think that's what people get so scared to come see us about. They don't know what's going to happen. And right, it's never too late to go see a pelvic health therapist. We can still help even years after treatment. On the far right, you do see the pelvic floor wand. So for those that are comfortable and need it, we can teach you how to use the wand yourself at home because your own digits might not be able to reach as deep as you need to. Next slide. So fascial and visceral mobilizations, these are the people have to take specialized coursework to be able to do these type of techniques. Everybody at the University of Kansas Health System has taken fascial mobilization, and it's a lot of internal organ moving those soft tissues to get things actually moving and working better. And not all therapists take these courses, but everybody should be able to help you with scar tissue mobility. Next slide. So I know somebody said they really hate vaginal dilation. So what I will say is if you are wanting to be able to participate in sexual activity with a partner, you're wanting to be able to comfortably tolerate medical pelvic exams, um, even I would venture to say bladder control because the healthiness of the vagina is important for bladder function as well as bowel function. We do recommend dilation, but completely understand if people are very averse to it. We're not going to force anybody to do anything, but for those who are really wanting to reach those goals, we're going to help guide you. So the dilators that you see on the top right, the one that has like a little bit of a cone shape to it and it's pointing down, it is a kind of a digital one. So you just push a button and it gradually expands out. It's not my favorite. It does have like a kind of a square shape to it. So it's not really a functional shape. The colored dilators or the intimate rose dilators, they are medical grade silicone. They do have some give to them. And I really like these for people who are dealing with vaginismus symptoms. So pain with vaginal penetration, where the opening of the vagina has gotten tight and those muscles are really clamping down. These are wonderful for those. And when you're not really kind of focused on the depth aspect of things, these are great. For people who've undergone pelvic radiation, I recommend the white dilators down at the bottom. They are all a standard 6 inches long. They are firm. They have a little bit more weight to them. And so they are not going to bend and give in that vaginal canal that has been really tightened down by radiation. Whereas you see the intimate rose dilators, the smaller the circumference, the shorter they are. So they're really not great for the depth if you can't accommodate a larger girth. Typically, we do recommend people dilate 1 or 2 times a day as able, anywhere from 10 to 30 minutes. Next slide. Now, because of our time, I'm not going to go deep into this, but just know this is the handout that we have provided our radiation oncologists at the University of Kansas Health System for those women who've undergone pelvic radiation so that they have good quality dilation instructions. So if anybody wants this, please just shoot me an email. I would be happy to send it to you when I get back to work on Monday. But this goes into those very specific details in the next several slides. So let's go to the next slide. Again, next slide. Next slide. And next slide. So you can see it's very specific. And I think one more slide. Yeah, there we go. Okay, so one of the other devices that I also do like to recommend for people who are dealing with that deep penetration pain, if we've done everything we can and we kind of still can't quite get what we need, maybe you have a partner that is particularly long, or you have sex toys at home that are also particularly long, and we're dealing with that pain. This is like a penis or toy donut. Like it is just not going to allow the full length of whatever's being inserted to go all the way in. They are very stretchy. You can use as few or as many as needed, and it's a really easy to use device. Next slide. So I mentioned previously that we will refer. So sometimes we might need to get pain management on board and help them get you started with some other interventions so that our interventions in the clinic can actually be more effective. Again, counseling can be really, really helpful. Your body has changed. You've been through a lot. There's so much stress that can be involved with hearing the big bad C word, and counselors can be so, so, so helpful for these things. And we have some excellent counselors in the area. And then, as a side note, for some people who have pelvic organ prolapse, we might also refer you to urology or a urogyne to help with a pessary fitting. So, a pessary is an intravaginal support device. They're typically made of a medical grade silicone that they insert into the vagina, and it just holds everything in place and can reduce symptoms pretty significantly. So, you might see that for just pelvic organ prolapse or also stress incontinence. They can be worn for upwards of 3 months straight for those people who are not able to take them out themselves. And then you just go in regularly to the doctor to have it removed, cleaned, checked, and then reinserted. But a lot of them, if you can reach in and insert and remove, you can do it yourself anytime. They can be worn all the time or as needed. Next slide. So I know not everybody lives in the Kansas City area, so I wanted to put some resources on here for you. For finding a pelvic health therapist near you, you can go to pelvicrehab.com or www.aptapelvichealth.org/PT locator. So those links are right there. And when you're looking for somebody in your area, check their biography. Look at what are they into? What are their passions? And I listed out some of the credentials on the right so you'd have a little bit of a better understanding of what those letters mean. So I myself am PRPC. We have a clinical therapist in our office that's WCS. But if you see these credentials after anybody's name, they've taken extra time and effort to study, sit for this exam and get that certification, but they are not needed to be a good therapist. So I just want to put that out there. Next slide. All right, one final thought from me. So I know that Dr. Lee was talking about, all of these symptoms that go potentially unheard and ignored. I also want to emphasize that for any of these symptoms you're experiencing after undergoing cancer treatment, understanding that we are still thankful to be here, that everything went well, but we still want you to have a good quality of life. So do not hesitate to bring up any additional symptoms that you're having with your providers because we are here to help. And that's all we want to do. We don't want you to just survive. We want you to really thrive. Okay. So thank you so much. If anybody has any questions, you have my email and office phone number right there.
Thank you so much, Dr. McCullough. I saw so many things in the chat, people agreeing and saying, I wish I had this. And just so everyone knows, we are going to gather information shared by both of the expert speakers this evening to make sure whatever we're allowed to share, we're going to get it out to you. So don't worry if you were trying to feverishly take pictures or write down websites or anything like that. We will get the shared information out. So I know we are closing in on an hour, but we are going to keep going. So please don't feel bad if you do have to drop off. We completely understand the webinar is being recorded, but we are going to go ahead and move forward to the next slide, please. We have another survivor story, and next we are going to be hearing from Maritza, and she is a cervical cancer survivor and actually most recently, very recently, just graduated from our most recent survivor school. So Maritza, if you would go ahead and share a little bit of your story with us.
Hi, good evening. So my name is Maritza Manjarres. I'm from Southern California, specifically Compton, California, and I'm a stage 3C metastatic cancer patient. I was diagnosed at the age of 34, but my story began actually 10 years before that with my abnormal pap smear. And in 2009, that was in 2009 when HPV was confirmed. After some time, my HPV turned into they call it CIN2, CIN3, and then abnormal cells. Years later, became precancerous cells, and for which I started some treatment. with a colposcopy, then a cryo, where they freeze the cervix to remove the tissue. Unfortunately, that didn't clear it. And then I underwent what they call it I don't know if I'm saying that right, conization of the cervix. So I had a cone biopsy to cut off the area with the cancerous cells. All that didn't work still. Didn't clear it. So I was diagnosed that's when I was diagnosed with stage 3C cervical carcinoma that had unfortunately spread to the lymph nodes in July of 2019. I underwent 7 rounds of chemo to start off, and 33 rounds of radiation along with brachytherapy. That was the beginning treatment. Unfortunately, 8 months later, I metastasized to the lymph nodes on the left lung. And I then started a more aggressive type of chemo in April of 2021. I know I forget if I was a cisplatin first and carboplatin. And so the third time around, actually, no, the second time around, I think it was carboplatin. And then, so after I finished that second treatment, I started on immunotherapy on Keytruda. I was on Keytruda for about almost 3 years. And during that time, the PET scans showed some improvement. They showed almost no signs of cancer up until July of 2023, when it metastasized again, recurrence to the lymph nodes again, but this time on the right side by the groin area. So then here we go again, underwent chemo again, but now, of course, it was more advanced. Now that it was more advanced cancer, it changed to a stronger, they told me it's a combination of immunotherapy and chemotherapy, which is called Tivdak. And I have been on Tivdak for the past, I want to say, 1.5 years now. I'm on a break as of the last month, almost 2 months, because of my side effects. Throughout the whole journey, my symptoms have been, of course, a lot of the symptoms that the doctor mentioned, which is depression, lymphedema, neuropathy is a huge one that I'm dealing with now, which is it's numbness and tingling to my hands and feet, and my feet tend to get numb, my legs as well. And then because of that, I've had several falls within the past couple months. I've had skin changes, I've had anemia, several blood transfusions, radiation proctitis, radiation cystitis, kidney problems, bladder problems. So it was very interesting to hear the pelvic floor specialist right now talk about that, because I'm actually starting pelvic floor therapy soon, so I'm excited for that. And I've been battling for 5 years, almost 6 now. So yes, you can get that after years of after treatment and during treatment, because I'm still in treatment. So yeah, that's my story, and I'm here to share my story so that no one else, or to prevent other women go through this alone, and to get the information out there. And yeah, my biggest goal, my biggest dream is to become a good advocate, and also advocate for the vaccine. And yeah.
Awesome. Thank you so much, Maritza, for sharing and getting into your experience and what your journey has been like. And then also how fitting that you are going to be starting pelvic floor therapy soon. So, how about that? You'll have to report back to us and let us know how it all goes. So thank you for sharing. And I know I speak for everyone. We'll be thinking of you as you continue your treatment journey as well. So thank you. All right, so we are going to, if you could go to the next, yep, perfect. So there were some questions in the chat, and I just want to reiterate some of those answers that we did get that maybe you didn't catch. Dr. McCullough did answer a question that came up while she was speaking of that, yes, even if you are a long-term survivor or far out from treatment, for your gynecologic cancer, that yes, you can potentially still see benefit and still be referred to see someone for pelvic floor therapy. I know that was asked a few times. And of course, she shared her clinic information, but everywhere is going to be different. But this is a specialty type of care that you would more than likely need a referral for. Um, One question I kind of want to ask that any of our speakers can jump in, or even you in the audience, if you want to chime in the chat, I'd love to hear from you as well. I know each of these gynecologic cancers has our own little awareness month, right? I know ovarian is this month in September too, cervical cancer in January, and we each have our own colored ribbons. But coming together tonight to talk about all GYN cancers was really special. So I want to ask again, any of our speakers feel free to unmute or chime in the chat as well. How can gynecologic cancer patients, survivors, caregivers, providers work better together to come together and continue raising awareness efforts during such a big month like Gynecologic Cancer Awareness Month?
So I know here at the University of Kansas Health System, our marketing team works with the Royals. And so they actually do themed nights at the Royal Stadium. And so they'll have like prostate cancer awareness night and cervical cancer night, breast cancer night. And, they might bring the doctors out. And like I got invited to the prostate cancer one a few years ago. And um, so in your own area, maybe seeing if that's something that could get started at something that already has a lot of exposure and seeing if they would be willing to celebrate one night with everybody and come up with something that way.
Great idea. Thank you. Anybody else want to chime in on ways we could collectively work together for gynecologic cancers? I know someone wrote in the chat, an event like this is even just so helpful to bring everyone together rather than each women's cancer do its own thing, because we do have so many similarities when it comes to the treatment options and especially the challenges and things we face throughout survivorship are so mirrored in so many of us, no matter what type of GYN cancer we have. Yep, Claudia wrote in the chat to collaborate more together. Someone else shared tabling at your local cancer support center or treatment facility. Someone shared these type of webinars seem to be a good start, and I couldn't agree more. Any of our speakers want to chime in or have any final
Yeah, I
thoughts?
think just like kind of bringing it back to like women's health, because I think in the beginning of the chat, people were really talking about like, we take care of everybody else, or we like do all of these things and we get busy and like, so like kind of bringing it back and then sort of, because that can sometimes also hit at people who've not experienced a cancer diagnosis, but maybe not taking care of their own health in different ways or have another issue. But so like kind of bringing it to be a little bit more like the symptoms and the recognition that there's kind of like a cluster of symptoms that could be a lot of different things. And so sometimes that differential may be a GYN cancer, but we don't know what it is, if that makes sense. And so
Right.
I think, and then anybody who has like a specific like awareness month, like I always feel like we had a breast cancer organization locally that did great. And we were so excited when they were like, we actually want to like do cervical cancer now. And we were like, oh my God, thank goodness, right? Because it was like they were reaching women, but they were like only talking about cervix, which is also really important because they were like navigating for very specific screening, right? So it's not like we shouldn't have those organizations, but it was great for them to do that. Or when an organization will just have like a month where they do that. I think any of the breast cancer organizations could be really great resources to say, like, we know you do breast like 12 months a year, but September before your October month, like, can you do an emphasis on like women's health and that? So I'd love to see some
Absolutely.
of those connections.
Absolutely. I've always said, there's a little twinge of jealousy, right, in the breast cancer advocacy space and how well established they are. But I think there's a lot other cancers and women's cancers can learn from the breast cancer advocates. And also, hey, let's team up, like you just said. I know you're gonna go hard in October for your awareness month, but maybe we can work together for women's health in general, or maybe highlight gynecologic cancer the month before with you in partnership. I think you just speaking also on women's health in general, because yes, we're cancer advocates, a lot of us, and sharing our story, but really getting the education and awareness out there, right, about these things, about your women's health in general. Know what's normal, know what's not normal. What do you do if you feel like something's wrong? How do you talk to somebody? I think all of that is really great advice. So thank you.
And just to add to that, I agree with everything that everyone said. It's just also building off of each other. So the awareness months are very important. Don't get me wrong, but this is going on all year round. Like women's health is happening all year round. So if we could also, like they're driving a lot of people in for mammograms for October, but that's when people may be seeing their gynecologists as well. So having stuff up in their offices at that moment might not be a bad idea either. They can kind of piggyback on that. And maybe a reminder or in people's signatures, reminder about gynecological cancer. And also know specifically that the pap smear does not cover all of them is another thing that it is amazing how many people don't know. So even if we had like those myths and facts that we can put out all year round, it would
Right.
be great.
Absolutely. Thank you, Mihal. All right. So thank you all so much. I'm going to tell you a little bit about a few things that Survivor has upcoming. So you're in the know there. So if you could go to the next slide. One more. Oh, this one. All right. So one of the next things that we have coming up at Survivor is going to be a Fuel Your Day nutrition workshop. And there is the link, but I think we're going to drop it in the chat as well. And this is, of course, open to all survivors. You don't have to only be cervical cancer. You don't only have to be GYN cancer. This is completely free and open as a workshop to everyone. Next slide, please. And we are very excited to share this information with you to save the date for Survivor's annual Cervical Cancer Summit, powered by Survivor, and that'll be taking place in January in Washington, D.C. And you can use the link that'll also get dropped in the chat. That is the link you can sign up to get updates. So we don't have registration open quite yet, but you can be the first to know as more details become available. And next slide, please. So tips and next steps. So we talked about a lot of different things today, but I also just want to share with you that your hope and your resilience throughout your own experiences and throughout the experiences of everyone you're helping and advocating for can be complex and challenging, but together we really can make a difference. And so I want us to all continue to spread awareness, educate, support one another, and become continuing advocates in this space. And so, ways you can do that: make sure your screenings are scheduled, make sure all the women in your life bother them like I do. Hey, did you have your screening yet? I know I always bother people. Share your story. This can be on the Survivor website, or if you have other GYN cancers, you can also find information from other organizations like the Foundation for Women's Cancer, as well as the CDC has information around gynecologic cancer. Use social media, use hashtags, and also support Survivor and other organizations that are working in this space. And another new way that we will be having to share, available to share your story, we'll drop the link in the chat. Another way to use your voice and raise awareness is for our caregivers. So whether there are caregivers in here or if your own caregiver wants to share their caregiving journey, that is going to be open to all cancer caregivers, not just cervical cancer. So we will be looking forward to hearing from some caregivers and getting them involved in advocacy as well. Next slide, please. So thank you again for joining us, everybody that joined as a speaker, everybody that joined in the audience. Thank you so much for your participation, our 2 expert speakers and our 3 incredible survivors who shared their story with us tonight. And just know and remember that truly together we can create a community of support and advocacy. So let's keep the conversations going and work towards a future where everyone has access to quality care and resources. So until next time, stay resilient and keep moving forward. And like I said at the start, everyone who registered for this webinar will be sent an email, and that email will make sure some resources from our speakers are in there, as well as a little survey. And of course, you are more than welcome at any time to reach out to anybody at the team on Cervivor as well. So thank you, Dr. Lee. Thank you, Dr. McCullough. Thank you, Sandra. Thank you, Mihal. Thank you, Maritza. And thank you, of course, everybody in the audience. And I hope everyone has a great rest of their day. Thank you so much.